Senator, you mentioned this whole issue of prescription drug and opioids, and I really look forward to working with you on that issue and working with our leaders at the Indian Health Service to see that we really tackle that issue. And I'm also happy to welcome the Acting Director of the Indian Health Service, Rear Admiral Michael Weahkee. Welcome back, Admiral Weahkee. I'm very pleased to remind the subcommittee, my subcommittee colleagues, of your New Mexico roots. I'd like to acknowledge the other officials, which the chairwoman also did, but I'll do it again. Rear Admiral Tote, Rear Admiral Gary Hartz, and also Ms. Ann Church. Thank you all for being here with us today. I'd also like to recognize the important work that my chair, Senator Murkowski, has done in support of the IHS budget. Since I joined this subcommittee in 2015, I'm proud that we have increased funding for the Indian Health Service by 19%. We've done some good work, but we have much more to do. And speaking of that, let's turn to the budget. I appreciate that the administration's proposal for the IHS is relatively generous by comparison to the rest of the President's budget request. But the budget before us is still wholly insufficient to meet this nation's trust and treaty responsibilities and provide quality health care to American Indians and Alaska Natives. All told, the budget decreases funding for the Indian Health Service by 2%. Within that amount, the budget does increase funding for contract support costs, which is very important. It also recognizes the need to pay for staffing for new health care facilities and the need to continue investments to address urgent accreditation issues at the IHS facilities in the Great Plains and, as of late last year, the Gallup Indian Medical Center in New Mexico. But to fund these priorities, the executive takes and acts to other critical programs. Facilities programs are cut by 42%. Line item construction funding that's needed to build hospitals and health centers for tribal communities in New Mexico and other states have been waiting for decades is cut by 2/3. Funding for the Indian Health Professions Program, dollars that go directly towards filling vacancies and improving access to quality health care, are cut by 12%. Urban Indian programs, purchased and referred care, and self-governance programs are all reduced. Preventive programs are cut in half, even though Native Americans face some of the biggest challenges when it comes to access to health care. And much to the dismay of many tribes in New Mexico that I've heard from, the budget even proposes discontinuing federal funding for community health representatives. These are tribal members who provide essential health care services when health clinics are closed or too far away. These trade-offs are unacceptable, especially when we think about the work that remains to improve health outcomes in Indian country. Despite the fact that this subcommittee has fought to increase the Indian Health Service budget, we're still not where we need to be. We're still not providing all the resources on the ground we need to address preventive care or to tackle the epidemic level of mental health and addiction issues that Native communities are fighting to overcome, which I think my chairman was very eloquent about in her opening. We still have an unacceptable number of facilities dealing with accreditation problems, a problem that seems to be growing instead of shrinking. We're still seeing double-digit vacancy rates for doctors, nurses, and other clinical personnel. And despite some important increases just gained in the omnibus, we're not making the progress we need to replace the service's aging healthcare facilities. This is a matter of setting priorities, and my view is that this administration needs to work with Congress and make funding for tribal health programs a greater priority. While we're talking about priorities, I also want to stress a subject that's important to all of us on this dais. That's respect for government-to-government relationship that the United States government has with tribal nations. I have been deeply concerned by certain administration policies reflecting this relationship. This includes rejecting requests from tribal leaders who ask to be exempted from state Medicaid proposals that would take health care coverage away from tribal members who do not meet new work requirements. That's why I joined a number of members in January of this year to write the Department We questioned the department rejecting the request based in part on the rationale that granting such requests would, and quote, this is the quote, raise civil rights issues, end quote. I recognize decisions related to Medicaid are made by the Centers for Medicare and Medicaid Services and not the IHS. But the question of how the administration views government-to-government relationships with tribes is much bigger and more significant than any one program or bureau. I want assurances that the tribal leaders deserve, and the tribal leaders deserve assurances that this administration views its relationship with Native Americans as trust-based, not race-based. Taking the latter position would reverse 2 centuries of law and Supreme Court decisions that have very firmly underscored the political nature of this unique relationship. That would be a non-starter. I know that I'm not alone in this position, and I expect this administration will face stiff, bipartisan opposition if it tries. It also bears emphasis that any changes that discourage tribal participation in Medicaid would also impact the service's bottom line. Thanks to Medicaid expansion under the Affordable Care Act, IHS has expanded access to health care for tribal members and greatly increased its third-party reimbursements. So I would also have serious concerns, both legal and fiscal, about any effort to limit the ability to use Medicaid funds to supplement IHS dollars, and doctors, of course. I look forward to talking more about this issue and many others when it's time for questions, and thank you very much, Madam Chair. Thank you, Madam Chair, and let me just emphasize what was said earlier. You know, last year we all requested this information when it came to these Medicaid cuts and the impact repealing the Affordable Care Act would have. And when it seems to me it's incumbent on you, when you put forward a budget that has Medicaid cuts in it, you analyze all the impacts and you're able to tell us specifically, very specifically, what impact is going to happen with specific facilities so that we can know what the result is going to be. As I mentioned in my opening, I've heard from a number of tribes in New Mexico who are particularly concerned about IHS's proposed budget that would cut preventive health funding by $81 million from fiscal year 2018 levels, including a complete zeroing out of IHS health education and community health representatives funding. As one Pueblo leader recently reminded me, community health representatives come from the communities they serve, which means that they have the necessary cultural understanding to identify and respond to their members. That cultural understanding is key to addressing the toughest public health issues on the ground, including substance abuse and addiction. And I would note that one of the key pieces of combating the opioid epidemic is putting more resources towards prevention, both addiction prevention and prescription misuse. Admiral Weahkee, do you see a misalignment between the goal of addressing prevention as part of a comprehensive opioid response plan and cutting preventive health care funding at IHS? Could you talk about the importance of these preventive health programs in addressing the opioid crisis?
Thank you, Senator Udall. And I'll start and then ask Dr. Todt to support me in this as well. With regards to the proposed cuts for both the community health representative and the health education programs, there are some concerns that have been expressed internally with the data that was available to be able to justify that these programs were efficient, effective, and accountable. Since this proposal has been released, we've had robust discussions with tribal leaders and other external stakeholders about the importance of the CHR programs and how they play a major role in our interdependent system of care. And they are the ones who are out in the community checking on elders and others with chronic health care conditions in some of the most rural and remote locations. So I've come to realize that there's a significant concern with the workload not being reported adequately, and so we're not receiving a full picture of what's actually being done by the CHRs and the health educators. So our data identifies that we've had more than 1 million fewer encounters or patient visits. However, we do know that those 1,600 plus CHRs that are working hard every day are doing their jobs, but they may be documenting their visits on a paper PCC is what we call it. It's a paper document that identifies the work that they did, and that information may not be getting captured when they return to the service unit. Also, we have interconnectivity issues with different EHRs being used. Our CHR line, about 95% of the community health representatives have been contracted or compacted. And so the majority of that work is taking place in tribal communities. And in the health education side, about 70% of the health education program has been contracted and is being run by the tribes. So I think we have a data issue in not being able to capture all of the work that is taking place. And I would ask Dr. Tote to share a little bit more about some of the vital services that are provided by our CHRs and our system of care.
So we definitely value our CHRs. We have more than 1,600 community health representatives representing over 250 tribes in all 12 areas. And we know that the services that they provide include patient visits related to diabetes, dialysis, hypertension, nutrition, and heart services for elders. And we've heard loud and clear from tribes that they value this program. The budget priorities were to prioritize direct care services and are no reflection on the value of the CHR program.
Yeah, thank you very much. And I would just emphasize again, I mean, I've heard from many of my tribes, and I would just add, like to add several letters from my pueblos to the record, Madam Chair.
They will be included.
Thank you. The couple of questions about the Gallup Indian Medical Center. I know my time's running out here, but Admiral Weahkee, I remain concerned about the continued identification of deficiencies in some IHS facilities, including the Gallup Indian Medical Center, which have put their accreditation status at risk. This committee asked for a formal report and update on the situation in Gallup, and we look forward to getting that report. But I'd still like to get an update from you this morning on where things stand. So could you give me just a brief update on that, and then I'll follow up with some additional questions.
Yes, sir. Thank you, Senator Udall. I think the best report is an objective report, which is we just recently had CMS in the facility 2 weeks ago. They came in with 11 surveyors, a very robust team, and spent an entire 5 days on site. At their verbal closeout, there was no reported EMTALAs, no reported immediate jeopardy findings. We are still awaiting their written report. There's not always congruence between the verbal closeout and the written report, but we are waiting to see what is put to print. More than 400 man-hours of review were conducted, and we believe we're on track to have both Joint Commission certification or Joint Commission accreditation and CMS certification back in place at Gallup in the very near future.
Great. Thank you very much. Thanks, Madam Chair. Thank you, Madam Chair. Back to the Gallup Indian Medical Center, Admiral Weahkee. First, were any services offered by Gallup Indian Medical Center ever suspended for any amount of time as a result of the findings of CMS and the Joint Commission?
So not exactly tied to the findings of CMS and Joint Commission, although we have intermittently had to divert or suspend operating room procedures because of humidity control issues. So there have been episodic suspensions of service as a result of facilities issues.
And how were those cases handled then?
Usually by site, staff on site adjusting the system to reach the minimum threshold controls. And part of it is due to, I guess, the weather in Gallup.
Yeah. Okay.
I've got an engineer to my left who may be able to help us more here.
Yeah, Mr. Hart, you want to weigh into this? Could you do your microphone, please?
Apologize.
Thank you.
It's actually very variable depending on, the weather conditions, and if, it's normally not common, but when the humidity might go up in Gallup, the capacity for the HVAC to deal with it always isn't as good as it should be.
Yeah. I understand that CMS conducted a full hospital survey of the GIMC starting on May 9th to inspect whether previously found deficiencies have been corrected. First, are you confident that IHS has resolved all the items identified in last year's survey and outlined the corrective action plan submitted to both the Joint Commission and CMS?
So there are a number of items included in that list. Some were able to be taken care of on the spot. Others, the team took care of in very short order. One example was the waiting room for the ED had patients who were also waiting for urgent care in the same waiting room. So they had to actually separate those two clinics. They did it over a weekend, and they are now providing services out of a different location in the hospital. So it resolved that finding. But some of the longer-term fixes with the environment of care and life safety will take longer to remediate, and those are mainly with the facilities infrastructure, with the heating and air conditioning and other renovation work that needs to take place.
Do you anticipate any new findings that will need to be addressed? And if so, could you share with us what your planned next steps are?
With specificity, probably not at this point, since we don't have CMS's report back to us. I think we're expecting that to come within the next couple of days, and then we'll have 90 days to develop the corrective action plan for those longer-term fixes. But would be happy to have a side conversation with some additional detail.
Okay. Should CMS identify additional deficiencies, how will you pay for the needed improvements? Are you confident that the $58 million proposed in your fiscal year 2019 budget is sufficient to meet these needs and still address other accreditation emergencies? Would the proposed reductions to the facilities have any impact on your ability to respond to these accreditation issues?
Thank you, Senator Udall. Well, with regards to Gallup specifically, and I think as a result of the expanded reimbursements through Medicaid, that facility has additional financial reserves that some of the other facilities in South Dakota did not have access to. And so they have a greater ability to take care of some of their own needs. But we do and would also have available the accreditation emergency fund should there be a large ticket item that needs to be addressed.
Okay. Admiral Weahkee, I can't emphasize enough how important it is to address any remaining issues at the Gallup Indian Medical Center and address them promptly and completely. I'd like your commitment that you will provide the report that this subcommittee requested on time, and that you will work with me to provide updates and make sure that this facility has the resources it needs to address these challenges going forward. Will you make that commitment to me?
Yes, sir, I will. Thank
you very much. I'm also encouraged to hear, shifting over now to substance abuse and the NCI detox, I'm encouraged to hear that the Preventing Alcohol-Related Deaths program has contributed critical resources, the Ogallala Sioux Tribe and the City of Gallup, through the NCI detox to combat alcohol and substance abuse. I understand that IHS officials recently convened with both programs in Gallup to conduct a site visit. Can you briefly update us on the progress these programs have made as a result of this funding and technical assistance from IHS? And can you comment briefly on how the new high-risk unit established by NCI Detox, which coordinates with the Gallup Indian Medical Center to provide medically complex patient triage, has been helpful to improving patient care?
Thank you, Senator Udall. And we did have members of our headquarters behavioral health team there in Gallup. They brought Oglala down and had a joint meeting to share best practices across the two sites, as you identified. Dr. Tote's going to provide a little more specificity. In general, the visit went very well, and both locations are doing great. We do expect to provide the next year's funding by the end of this fiscal year. So nothing that we saw that would get in the way of that continued support for those two programs.
Yes, sir. We definitely appreciate the funding in the Preventing Alcohol-Related Deaths program, and absolutely the site visit shows that there are promising signs of increasing access to treatment and good quality, high quality, culturally appropriate care. We were really encouraged to see the collaboration between the programs and the sharing of best practices as well.
Great. Thank you very much. Thank you very much, Madam Chair. And as we know, I mean, this case was originally Alaska, but it's starting to have an impact, I think, all over the country. And we haven't had, Chairwoman Murkowski, the extended conversations we need to have with IHS. We need you to come back and talk to us and give us the specifics here. We haven't gotten updates about the impacts of this case. And we would encourage you very much to talk with us also at Indian Affairs. Both of us are on the Indian Affairs Committee and give us an update as well as this subcommittee here. On the health facilities construction funding for New Mexico, I'm very pleased that this subcommittee was able to provide the largest ever appropriation for facilities construction and maintenance programs in fiscal year 2018. There are a number of projects in New Mexico that have been waiting a very long time for funding, including health clinics in Alamo and Pueblo Pintado, as well as facilities in Albuquerque and Gallup, an obvious priority given the issues we have already discussed today. Can you please provide an update of what the fiscal year 2018 funding level will mean for these specific facilities?
Thank you, Senator Udall, and I know that Admiral Hartz has been dying to share some good news, so I'd like
good.
to...
Please, Admiral Hartz, that would be good.
I thought I was going to get a break today. I first of all, thank you very much for the question, Senator, and thank you for the opportunity to speak to the committee. Indian country and the Indian Health Service much appreciates the increases to the facilities appropriation in 18 and following down the priority list that we've worked with this committee and the authorizing committees for some time and present annually. There will be for Alamo with the 18 appropriation that will wrap up the needed funding that will be going into that project, and we can provide for the record the details of the dollar amounts, but that will be wrapped up with that $48 million, so it'll be ready to move forward as long as the site, we don't have unusual site conditions. And Pueblo Pintado, the resources going in there will be ready to finalize the planning and initiate the site selection review activities there, about $10 million. And then for the Albuquerque Central and satellite facility, we put about $750,000 in each one to proceed forward with the planning for those. Essentially, a broader answer to your question is that we now have resources in all of the outpatient facilities on the priority list. There are resources to move along on every project on that list from an ambulatory standpoint.
Now, this subcommittee nearly doubled funding for sanitation facilities construction in the recent omnibus, and I know that this funding is very important for Alaska Native villages in the Chairwoman's state, and that we also have particularly significant sanitation needs in New Mexico, including a large number of homes on the Navajo area that lack access to clean drinking water and waste disposal facilities. Could you talk about the impact that these additional funds will have from a public health perspective? How many additional homes will you serve with these funds?
The,
Arts, I think you're a good one to jump into that there.
well, there's no question that we will make significant inroads with that additional $90 million that you provided to the Indian Health Service for this purpose. The exact number of those homes is actually yet to be determined, sir, and we will provide that for the record. The projects have been identified, and they're now going down to submit that information to us. We'll have that at year end. We may be able to get it sooner, but we will definitely provide that for the record.
Great, please do. Thank you very much.
You bet.
I was pleased that we were able to fund $50 million for tribal opioid grants through the Substance Abuse and Mental Health Services Administration budget in last year's omnibus. And I note that the budget request includes additional funding for the Office of the Secretary to fund opioid-related needs. What appears to be missing in the direct resources for the Indian Health Service's own budget, however? Could you tell us what impact the opioid crisis has had on the service's budget and what the greatest operating needs you have as a result? Has the IHS worked with SAMHSA to ensure that the grant resources that Congress provided are being used for the highest priority needs?
Thank you for the question, Senator Udall. The Indian Health Service has been making its substance abuse and suicide prevention funds, which is formerly the MSPI, available for, among other conditions, methamphetamine, heroin, opioid abuse, suicide prevention activities. So that amount for previous funding has been at $27.9 million, and the majority of those projects are focused on youth and youth suicide and substance abuse prevention. The funding for the President's budget that is the $150 million proposed for IHS, we absolutely want to get the voice of tribes. So as we stated before, we would have consultation with the tribes about how we can best use that money to serve their communities. With respect to the SAMHSA funding, the $50 million, and the coordination with getting the money to tribes, we have had several meetings with SAMHSA leadership. We've been having conversations about funding distribution methodology that the IHS uses and sharing those ideas and techniques with SAMHSA. Also, I was on Monday at a joint listening session with SAMHSA and NIH in Minneapolis addressing the opioid issue, and SAMHSA was directly consulting with tribes with IHS present as well.
Thank you, Madam Chair. Admiral Weahkee, I'm perplexed by the decision in this budget to cut funding from the Indian Health Professions Program by 12%. These are programs that provide scholarships and loan forgiveness to recruit the next generation of providers at IHS facilities. It's my understanding that even at current funding levels, IHS is turning away students seeking assistance. Could you please share with us what number of qualified applicants to the scholarship and loan forgiveness programs are going unfunded at current levels? And wouldn't your budget request mean that even fewer applicants would make the cut?
Thank you, Senator Udall. I also want to reference as part of my remarks some of the proposals that we've made, which would help to provide greater numbers of both scholarships and loans, one of which is to deal with the taxability issue of our scholarships and loans. Right now, a lot of our funding is going towards reducing the tax burden on recipients, and we'd like to have the same parity with the Armed Forces Scholarship Loan Program, National Health Service Corps, and make those non-taxable. That would enable us to provide more scholarships and loans. But to get specifically to your question and what we've received this year, for the loan repayment program, we had 1,267 health professionals receive IHS loan repayment. That's 434 new 2-year contracts and 396 one-year extension contracts, with 437 starting their second year. So we had 788 applicants go unfunded at an estimated cost of $39.4 million. And then for scholarships, we had 805 new applicants. 331 of these were eligible for scoring, and of those, 108 were awarded. An estimated $3.3 million would have been the need to fund all of the qualified new applicants. So we had 154 continuation awards funded in that most recent year.
Yeah, thank you for that answer. I want to shift over here with a final couple of questions on the IHS and health IT modernization. I know that health records and billing IT needs at the IHS have grown over the years, and I've heard from tribes concerning about what IHS's plan is to replace the RPMS, since the VA will discontinue support of it soon. This year's budget request acknowledges RPMS replacement as one of IHS's top IT challenges. And I quote here from the budget: "The loss of the VA as a source of software code will raise the cost of continuing to use the RPMS system and require IHS to procure commercial off-the-shelf replacements for RPMS," end quote there. It goes on to say that efforts are underway to look at replacement systems. Admiral Weahkee, what specific efforts are underway at IHS to replace the RPMS?
Thank you, Senator Udall. And our IT office has been in very robust conversations with internal HHS stakeholders and directly with the VA and the DoD on their experience in evaluating electronic health record solutions. As an agency, we'll put out a request for information for the public to provide us with their thoughts on what the IHS should do. We received responses from the big ticket vendors who were interested in coming in and replacing RPMS. We also had a number of responses for people who were willing to come in and maintain the existing RPMS system for us. And we've also received a number of add-ons, if you will, bells and whistles that could be added on to RPMS to make it more interoperable or provide better reports. So I would characterize our current situation as doing robust evaluation. We are watching closely, and we saw just last week that VA signed the contract with Cerner, so they are all in, if you will. But we do continue to have robust conversations with our HHS Chief Technology Officer office about what IHS and HHS should do moving forward. One last thought and some additional conversation we've had is with our tribes, and many of them have already made the investment and have moved forward to go on to private off-the-shelf EHRs already. And so we are leveraging the lessons that they've learned in making those conversions, and also the investment information, how much it's cost them to make those transitions, to help inform our future budget requests and how we'd like to move forward.
Given the budgetary concerns outlined in the budget justification, does the administration's FY 2019 health IT requests reflect RPMS replacement planning?
For the stage of evaluation that we're in currently, I believe that we are still pre-decisional in being able to justify a specific amount, but we will be closing up this initial phase of evaluation soon, and we'll be able to provide some harder and justifiable dollar amounts to proceed forward.
Admiral Weahkee, based on your summary of IHS's efforts to look at RPMS replacements, do you think the agency has done enough to pre-plan as much as possible for the difficulties of an IT systems deployment?
I believe that there is a lot of planning that will be needed, and we are operating on a shoestring within our existing IT, and to be able to go through as robust of a transition as will be needed, we will need additional resource, either contracts or a surge in capacity in our IT side of the house. So additional resources will be needed.
Yeah, well, I think it's really important that you make clear the resources you need to do this, because this is obviously very important, and going through the stage we're going through. Admiral Hartz, did you have anything to say here? That's fine.
Actually, Dr. Tote is our previous CMIO, so he may have some additional insight.
Well, that would be great.
Thank you, Senator. We know that there are significant challenges with RPMS. We have them at our federal sites. We've heard from tribes, and we know that the VA, having made its decision, just last week, gives us even more incremental clarity on some of the issues surrounding it. So having a robust and accurate proposal is the work that we're undergoing right now to make sure that when we put a request forward, that it has sufficient information. But I concur that significant additional resources would be required to make a transition.
Yeah, thank you very much, Madam Chair. Just, I think she said it very, very strongly, that when we get in this backlog area, it is, consistently, it just gives us the sense we're not moving. And historically, I've kind of seen, and it doesn't matter Democrat or Republican, some administrations have stepped forward with 5-year plans to wipe out backlogs. And, that's the kind of leadership I think we need from the administration, is just stepping forward and saying, we're going to take care of this backlog within a certain period of time, and we're going to ask the Congress, we're going to make a proposal, and we're going to ask the Congress to participate with us and try to wipe it out. But we need that kind of leadership, and I really appreciate your comment on that. So I'm not trying to get the last word. I'm just trying to fold into the words that you said, which were really the last words.